So as you noticed, we had a little change in the program, and I asked Dr. Amy Hilmer to fill in for Gene Lambert, who was going to come from Boston. He's part of the addiction medicine team at Mass General. He became ill, and Amy Hilmer, our own addiction medicine specialist at Mercy, graciously agreed to fill in and give us a really update on the interface, addiction and being unhoused. So, Amy, thank you so much at the last moment to fill in the gap that we had with Dr. Lambert not being able to come, and really look forward to your talk. Thank you.
Hi, everybody. Yeah, we made it to the end. The best for last, right? Nothing like coming in 5 days and pinch hitting for a nationally known speaker. So my goal is to have you walk away from here, and hopefully there's a couple things that you walk away with that I have either taught you or just kind of given you insight into. So I'm Amy Hilmer, Amanda Hilmer, but I go by Amy. I'm going to talk about substance use disorders amongst people who are unhoused. So who am I? This was the first thing that came to my mind when I had 7 days to prepare this talk. And it was something that was said 8 years ago. I went to an opioid epidemic summit when I was kind of early in doing this work, and it was experts from around the country. And there was a disconnect between what I was seeing on the ground and what I was hearing. A lot of it was people who were doing big data science. And I was sitting next to a nurse practitioner from Affinia Healthcare. Anybody here from Affinia? No, okay, but it's a strong group at Affinia, so it's a federally qualified health center. And it was a nurse practitioner who'd been doing the work for a long, long time. One of the original people prescribing Suboxone in our town. And we bonded, and she looked at me and she kind of rolled her eyes and she said, I am not an expert, but I have certainly done the work. And it stuck with me, and it sticks with me now. Another story I want to say, last night I got to go to dinner with the keynote speakers and Dr. Mannion, so thank you for that. That was intimidating as all get up. So I went home, I woke up at 3 in the morning, and I said to my husband, I think I'm going to pretend I have the flu. And he's like, no, you got it. There's going to be a sign that you were meant to do this. So I walked in today, and there are angels that walk amongst us. So I saw immediately Miss Terry Hicks. So raise your hand, Miss Terry Hicks, representing Places for People, where I worked for a long time. And so I went into addiction medicine because of 3 people. 2 were patients and 1 was Miss Terry Hicks. So we worked on who is an angel who walks among us. But we were on a team together, taking care of people who had substance use disorders, many who were unhoused. And it was when a light bulb went off in my head. And after doing medicine for, at that point, probably 15 years, I was like, this is what I was meant to do. So that's who I am. Here's a little bit more about me. I trained in internal medicine 25 years ago in this town. I've been lucky enough to work in the community health setting, so I won't beat a dead horse about federally qualified health centers, but that's where I got my wheels on the ground. And then from there, I got connected to Places for People. Do you guys know what Places for People? Have we talked about it yet today at all? Okay, so I think this is the Places for People table. So Places for People is a community health center that takes care of people who have complicated mental health diagnoses. Many have co-occurring conditions, so they have substance use disorders overlapping with mental health diagnosis. It is comprehensive. They have nurses who are working with them. They have caseworkers. They have peer support specialists. And we're going to talk a lot about that today. They have vocational training, and then they brought me in. So I was initially a primary care doctor, and then by default started doing treatment of substance use disorders. And then from there, I said, I've got to do more of this. I had so many questions about treating addiction that I needed to have the answers. And the answers at that point were Googling and looking on UpToDate. So I called Dr. Fred Rotnick, who is another legend. He's the godfather of addiction medicine in St. Louis. He had started the first addiction fellowship at St. Louis University. And he said, come on and be my addiction fellow. So I did a year of addiction fellowship and ended up staying on faculty at St. Louis University for a while. And I worked in 2 settings where I saw people who had both substance use disorders and were Unhoused. So I worked in a low barrier opioid clinic. We treated all substances. I don't know why I'm putting opioid clinic here, but we treated alcohol use disorder, we treated stimulant use disorder, and we treated a lot of people who had opioid use disorder. And additionally, and I'm very proud of this, I started the first dedicated inpatient addiction consult service at St. Louis University, which most of you know is a safety net hospital, tertiary referral center in our town. And generally, at least half of the people who were on my consult service did not have housing that we were going to be able to discharge them to. And so I learned fast. Not an expert, but I learned how to do the work. Oh, and I'm here now in Mercy, my new home. So I want to say a couple things about that, and I have another slide at the end. Unhoused people, it's a group that has a lot of heterogeneity. I didn't know how many people I would see when I came to Mercy who would be struggling with chronic homelessness. And I've seen quite a few in the hospital consult service, most definitely, but also in my job, we have a low barrier opioid clinic that's virtual. And I had someone just the other day who I'd met them on a video visit in their home, saw them 2 visits later, and they're now living in their car. So that happens a lot. So it's in our community. It's here at Mercy. It's not just something that's at hospitals that are far away. Okay, I start every talk off with this because I think it's important, because it seems so evident. What is a substance use disorder or what is addiction? But man, in the hospital, I hear the wrong thing all the time. It's not a urine drug screen that's positive. It's not that somebody used methamphetamine 4 times last week. So it is a syndrome. This is from American Society of Addiction Medicine. Addiction is a chronic relapsing disorder characterized by a compulsive drive to continue a substance or behavior despite adverse consequences, loss of control over intake, and the emergence of a negative emotional state during abstinence. That is a mouthful. But what I say to learners and to patients is, if you remember your 4 C's, then you're going to hit your criteria for the DSM-5 diagnosis for use disorder. So people have to have loss of control over their use. Generally, it tends to be compulsive. It's taking up more of their time to think about, how am I going to get a substance? Where am I going to get a substance? People have to have consequences related to their use, and that can be in all domains of their life. And then cravings, which always reminds me there's 3 physiologic symptoms of addiction: cravings, tolerance, and withdrawal. So as I was writing this, I was thinking, how does this look different, this diagnosis of use disorders amongst people who are unhoused compared to people that we see that have a safety net and have secure housing? And you can think in your head, and I would love to hear what you think. But for me, the first thing that comes up is consequences. Consequences look very different depending on who you are. If you have a safety net and you have money and you have a way to get places, the consequences come slower. If you are unhoused, or if you have challenging social determinants of health, they come fast and they come furious. American Society of Addiction Medicine had to actually have consequences related to the criminal justice system as definitively not part of the criteria, because it so disproportionately affects different groups. Briefly, the epidemiology: 44% of people who are experiencing homelessness qualify for a substance use disorder. I gotta put my glasses on. 65% report regular illicit drug use, so that's at least 3 times a week. Alcohol use disorder is the most common at about 40%, and of the drug use, or the illicit drug use, it tends to be methamphetamine, followed by opioids, cocaine, and then benzodiazepine. Often, about 60% of the time amongst this population, there is a co-occurring mental health diagnosis, and there's a bidirectional relationship. So if you are unhoused and don't have a predisposing or pre-standing use disorder, you're more likely to develop it. If you have a use disorder, you're more unlikely to be unhoused, and estimates are that you're 13 times more likely to end up unhoused if you have a substance use disorder. We've talked about this a lot, but I want to give some lip service to it also. There's nothing that I can do in the hospital or at a low barrier clinic if we don't say that housing first is the most important thing. And in this population, it means a little bit of a different thing. It means that people don't need to be sober before they get housing. It means that we don't need to say, hey, you have to be compliant with these different rules in order to get housing. And so it looks a little bit different when you're talking about somebody who's dependent on a substance. Just a little bit of data around housing first. So We know that people who have housing first and are in those programs remain housed 2.46 times as likely at 18 to 24 months as people who aren't in those programs. We know that it cuts healthcare utilization. So if you are using a housing first program, you're 37% less likely to go to the emergency room and 24% less likely to have hospitalizations. And so when you think of how we don't have money to do things, I think that we need to think about where are we saving things. So if we have people and they're not using the ERs and they're not using the hospitals, they may not be spending as much money on criminal justice issues, then we should be able to find the money to have housing. And there are economic models that will demonstrate this also. There is mixed data with treatment of substance use disorders. And I think that a couple things about this. The first thing is that I don't just tell somebody who has a home when I treat them for a substance use disorder to go home and now the treatment's done. You can get someone housing, but then you have to have all of the other things that go into treating a substance use disorder that occur after someone has housing. Additionally, you have to keep up the other support so that people can continue to thrive and get transportation, get their physical health, get their mental health addressed. Has anybody talked about trauma yet today? Maybe? No. Okay. I would be amiss in a talk about substance use disorders and people who are unhoused to not talk about trauma. Trauma is everywhere, and trauma is even amongst those of us who've taken care of people who are chronically traumatized. So similar to talking about addiction, let's have a working definition of what trauma is, because it's something that, again, is kind of thrown out all the times, but it means a very specific thing. So trauma refers to an event or a series of events or circumstances that are experienced to an individual as physically or emotionally harmful or life-threatening, that has lasting adverse effects on functioning and well-being in all domains: mental, physical, social, emotional, and spiritual. Overlap with this population is huge. Amongst people who have substance use disorders, 70 to 80% will report a significant traumatic event. And amongst people who are unhoused, it approaches just every single person. A statistic that I think kind of hammers that home is that 52% of unhoused people report assault in the previous year, either sexual assault or physical assault. So I want to go back and say one thing about that. Trauma affects our body in real time. Two things that I want to say about it. One is that we know that with epigenetics, the DNA that ends up being represented in our bodies when we've been traumatized is changed. The DNA we pass on to children is changed when we're traumatized. Trauma affects our neurobiology in many ways. I'm going to touch on one, which is that our amygdala becomes hyper-functioning, and essentially we are always in a state of hyper-awareness, emotional dysregulation, fight or fright. And what does this look like in the hospital? Well, on my addiction consult service, it looks like a difficult patient. It looks like somebody who is drug seeking. It looks like somebody that the nurse is having conflict with. So get used to what trauma looks like in the hospital so that you can prevent re-traumatizing. Trauma is especially significant when it occurs before the age of 18. And I'm sure many of you have heard of adverse childhood experiences and the work done around this. This essentially is looking at 10 different severe traumas that can happen to children in the realm of abuse, neglect, household dysfunction, and then following the outcomes and seeing where it correlates with different physical health, mental health, and socioeconomic outcomes. So it correlates quite a bit with substance use disorders and people who are chronically unhoused. So we know that people who have at least 4 or more adverse childhood experiences are 3 times at risk of having tobacco use disorder, 4 times at risk of having alcohol use disorder, and 7 times at risk of having a substance use disorder related to illicit drugs. Additionally, we know that that overlaps quite a bit with the unhoused population. So 90% of people who are unhoused report at least 1 adverse childhood experience, and over half have had at least 4 adverse childhood experiences. And so we know that people who've experienced neglect before the age of 18 are 13 times increased risk of being unhoused, Physical abuse, 16 times the risk of being unhoused. So if we know that everyone that we're taking care of has experienced trauma, then the second thing that I would be amiss to not talk about is trauma-informed care. And trauma-informed care should be a part of what we do in every clinic, in every hospital that we participate in. So trauma-informed care recognizes the widespread impact of trauma on a patient's life and aims to prevent re-traumatizing by promoting safety, trust, and empowerment in clinical interactions. How many people have seen patients re-traumatized in the hospital? Yeah, I just saw one like a half an hour ago. And so, yeah, it happens all the time. And if you have a substance use disorder, I don't have this study, but I would think if you are dependent on opioids, I'm going to predict 75% chance that you walk into the hospital and that you will be re-traumatized. And so the first step is recognize that's what we do. And so what it proposes is that when you see that challenging patient who you're spending more time on and conflict is going on, you ask yourself, what happened to this person, and stop asking what's wrong with this person. Sometimes it takes just sitting down and saying, whatever's going on right now in front of me, I'm going to just let it go and listen to what they're talking about right now. And it may have nothing to do with what the medical plan is or what the substance use plan is, but it has everything to do with what this person needs right now. All right, I'm going to skip over this. Suffice it to say, there are very good models for systems, for clinics, and for individuals to implement trauma-informed care programs. Okay, now I'm going to shift a little bit to me personally, and I think a lot of people have said things that are very similar. I came in sort of a novice when I started doing this. When I first worked at a federally qualified health center. And what we're trained, especially 25 years ago in medicine, is that we have sort of this agenda that we got to talk to people about. How are your blood sugars? Are you exercising? What's your blood pressure? And I carried this over to my work when I started working primarily with people with substance use disorders. So I would just go in there and go for it. How much fentanyl you've been using every day? How are you using it? How long till you get withdrawal? And this works sometimes. Sometimes being very direct is helpful. But what I've found with people who are struggling with severe social determinant of health challenges and substance use disorders is that you have to know what's most important. And the best way to know is by asking. So I would say 80% of the time in the low barrier substance use clinic that I worked with, the first thing that people wanted to talk about was their basic needs. And how do you know that? You ask them, what's the thing that's most important to you right now? And generally it starts with the things that you all have talked about today: food, shelter, safety. Safety is a big one. Wound care, that would always be good when they would say it, because I'm like, oh, that's my lane. I can talk about wound care. But the other stuff I got comfortable with. And it's not, hey, let me just find a social worker and they can talk to you. It also becomes that I have to start knowing what some of those things are and understanding so that I can talk to people about it. After that, harm reduction. I'm going to talk a little bit about this in a second. My first agenda when I'm seeing people is that I want them to be alive and I want them to be safe. And that's a powerful thing to say to someone. And I know a lot of people here say that to people too. But if you lead with that, then you can figure out down the road how you're going to take care of the other things. The next layer, I'm biased because I treat substance use disorders, but I think if you don't address the substance use disorder first, you're not going to have a good chance of being able to make the diagnosis that is their mental health diagnosis and to address their physical health needs also. And so being really comfortable with talking about what substances people use, how they use them, and saying it in a way that's just very conversational was something that I got very good at. And then the final thing I want to give a plug to after physical health is legal needs. And the reason I put this up here mostly is it's amazing how many people don't get methadone treatment. And methadone is not a dirty word, but it's amazing in this town how many people don't get methadone treatment because they do not have a government issued ID. If you walk the walk with somebody who does not have a government issued ID, it's almost impossible. It's impossible. It is, and it seems like the simplest thing in the world. And I know that there's actually a charity that helps people do it. But simple, very simple things mean everything to the plan that you create. Okay. This is me talking about the words that I say amongst the healthcare community and the words that I document in the chart. People who are struggling with addiction can use any words that they want to use. People who are unhoused can use any words that they want to use talking about themselves. But if you're working with me on my team, words matter. And that includes what you say, but it really includes what you put in the chart. Stigmatizing words make a huge difference when someone comes back in the hospital and they immediately read, this is someone who's drug seeking. And so I just want to go through some of my top favorites of what not to say. In general, just be factual and describe the situation. Polysubstance abuse, even polysubstance use. I know, and this is my own pet peeve. It tells me nothing. What does that mean? Tell me if they have an opioid use disorder. Tell me if they use methamphetamine a couple times a week. But when you say polysubstance abuse, it says nothing other than this person is someone who uses drugs all the time. And suddenly they go from someone I want to treat to somebody that I'm kind of worried about going in the room for. Drug seeking, there's better ways to say if you think that somebody might be trying to ask for more pain medication than they need. First of all, it's a conversation with people. Are you dependent? And that's a different conversation than, hey, I don't want to give you more pain medicine and this is why. But don't put drug seeking in the chart. Everything should be person first. It's not a fentanyl user, it's a person who uses fentanyl. I'm really good about this with substance use. I'm not as good when it comes to other things. I catch myself saying diabetic all the time, but in general, get used to using person first language. Clean implies that if somebody's not clean, they're dirty, and people aren't dirty. They're either using, in remission, relapsing. There's other ways to say it. Addict is a person with a use disorder, unless you are using, and then you can say whatever you want to say, but providers, we cannot. And alcohol use disorder is what you say for alcoholic. And then the one that drives me the most crazy is trading one addiction for another, because methadone and buprenorphine are evidence-based treatments that are better than almost any treatment we have for any other physical illness. Okay, harm reduction. Many of you know this. Harm reduction is two different things. Initially, it was a movement started by people who use drugs and people who love people who use drugs. That was based on movements from people who had HIV in the 80s. And essentially it said, we matter. And because we matter, we should get treatment to stay alive, even if we aren't ready to have treatment for our use disorder yet. And from that came what I think of as pretty common sense ways to help people stay healthy, stay alive. One, because it's the right thing to do, but two, because then you engage people so that they can get treated in another day. So these are ones, there's a lot more, but these are ones that are pretty obvious. So naloxone, the opioid antagonist, it's a reversal agent, needle exchange programs, and educating people about safer ways to use syringes. This one is my pet project, and it's opioid tolerance. And it's probably my big mission in being a hospital addiction provider. Nobody should be sitting in the hospital who's dependent on opioids withdrawing. Detox is asking for someone to be discharged, to go use a substance again, use an opioid again, and overdose. Allowing people to be treated with opioids so that they're not in withdrawal when they're in the hospital is not only the right thing to do, it's something that will keep people alive. And the hospitals are kind of catching on with that. But I do still see a lot of times where that's really resisted, and I go up to see people and they're still sitting in withdrawal. All right, so general treatment for all substance use disorders, so this isn't going to necessarily be specific. A lot of these things were said before. I have the van there because that's a van that gives people medication for opioid use disorder, and I always wish that I could be a doctor who went and did that in a van, but I haven't been yet. And so we've said before, I worked in a brick and mortar setting, and we missed a lot of people. And so I'm really happy to hear Dr. Nolan talk about actually prescribing buprenorphine for people and bringing it to them where they are. Additionally, for all people who have use disorders, you have to think, how am I going to get them through this initial withdrawal period, and how can I do it safely? Sometimes that's going to be able to accommodate where people are, but sometimes really people have to be in higher levels of care. We know that the treatments for substance use disorders include medications and psychosocial treatment. So of course, people should have access to group therapy and individual therapy. And then I'm going to talk a little bit more about peer support in another slide. So specific to substances, mainly the thing I wanted to say here is that we have two buckets. We have medications that we use to treat use disorders, and we have psychosocial treatment. And depending on the substance is the combination of those two that you use. This is really my plug to say that for opioid use disorder, it's always going to be a medication first approach. And then, for stimulants, it's more psychosocial treatment. And for alcohol and benzodiazepines, it's a combination of the two. And probably the thing that I found most important in taking care of people who are really struggling with challenging social determinants of health is alcohol and benzodiazepines can have a very dangerous withdrawal syndrome. And so do a good job of triaging and knowing what people are going to, how much danger they're going to have of having really dangerous withdrawal. Okay. So I put some of the people that I've encountered in the last 10 years working as an addiction doctor and some of the truisms that they imparted on me. So this is Jay Hartman. Does anybody know Jay? He was a med student at St. Louis University. So he was a social worker before. He worked in a shelter for unhoused people in Seattle for 2 years. He's an addiction psychiatrist now. He's an awesome human being. But he was the very first med student I had the very first day that we did the addiction consult service. And we saw somebody and it was a challenging encounter. And I think I was nervous, frazzled. And he looked at me and he goes, Dr. Hilmer, generally we as human beings do what it takes to meet our basic needs. And I think about this all the time. It comes up all the time. Somebody sneaks fentanyl into a room in the hospital because they know they're going to withdraw and they don't want to leave the hospital because they're having such a severe infection. They're getting their basic needs met, right? Somebody brings their laundry, takes an ambulance ride to go to the emergency room, gets their laundry done there, they're having their basic needs met. Once I start thinking about things in that paradigm, then it's no longer that somebody's compliant or not compliant or doing things that are bad or not bad. We're all just trying to get our needs met. And for some of us, it's very easy to get our needs met. But for a lot of the people that I've taken care of, it's really, really hard. And so beyond just addressing what we talked about before, which is withdrawal, one of the things that I think goes into talking about basic needs is everybody's using a substance for a reason. And we should be asking them, what is that reason? So just some things that come up. People who are unhoused are worried about safety. They're using methamphetamine so that they can make sure that they can stay safe. Everybody's got a reason that they wish they weren't using or that they're at least thinking about it. Ask them that too. So that's motivational interviewing, right? That's the basic of it. Why are you using? Why aren't you using? And just trying to figure out how you can navigate those two things. I don't know why that picture isn't working. Is Amanda here? Your picture didn't even go up. I'm sorry. The other thing, if somebody with lived experience wants to teach you something, someone who's in the field, listen. This is most important with peer support specialists. I've been super duper lucky. I got to work with peer support specialists from the very beginning of my fellowship. I don't here at Mercy, but up until now, and hopefully we can get some peer support specialists who are here. These are people who have lived experience, who've gone through training so that they have a unique skill set so that they can work with other healthcare providers to help meet people where they are, help bring people into care, and help teach the providers things that they don't know, how to do practical knowledge and bring that into care. And so I think that that's where the magic happens, is working as an addiction doctor with peer support specialists. I also want to say, because of what I do, I've had lots of doctors and nurses and social workers who've also come and shared with me their story of struggling with a substance use disorder. and then helping me understand things that I might be doing, that I could wrong, that I could do different with my care. And they've been some of the best lessons that I've learned. So be open to that there are people who know, not just because they're doing it, but because they've gone through things too. So there's data around peer support specialists. It helps with reduction of substance use, decreases relapse rate, improves retention in clinic, improves satisfaction, and reduces utilization of acute care. And I think amongst people who are unhoused, it's even more important. We talked about this hierarchy and this caste system, and it really helps break it down. And then I think most of the SLU people are gone now. There's Dr. Fernelius over there, but this is my crew from SLU. This is SLU Addiction Medicine, and they're all wonderful, wonderful people. But what this reminds me of is promoting a culture that normalizes substance use disorder and the care for vulnerable patients in all settings. So I'm a touch point. If somebody's admitted in the hospital, I have an opportunity to see them and talk to them about their substance use disorder that I wouldn't have if they weren't admitted in the hospital. I can use that touch point, or I can just let it go. It's a huge opportunity, though, amongst people who don't have that many opportunities to meet with an addiction doctor. And so I challenge people who aren't addiction doctors who are working inpatient to use that opportunity too. You won't just address people's withdrawal, you'll also be giving them possibly medication that treats their opioid addiction. Outpatient is a touch point too, but I want to give a shout out to emergency room doctors, because they, as we talked about a bit before, are often the first place where people are encountering people who are unhoused, who use substances. Pregnant patients have insurance for a brief amount of time who may not normally have insurance, so that's a touch point also. And then additionally, we have a lot more medical students and residents who are now being taught about substance use disorders, which is super exciting, because I think 25 years ago, we didn't have that. So I mentioned a little bit in our own Mercy community that we are doing the work here also. So we have the new inpatient service, and then VSERP. These are VSERP people that I have in this picture right here. That's the virtual substance use program. It essentially is bringing a low barrier clinic to people in our Mercy community. You have to have access to a smartphone or a device in order to do it, but it is doing good work. Additionally, we have the BRAVE program here, which is care that Dan Jackson is doing for women who are pregnant who struggle with substance use disorders. And then this is another peer support specialist that I worked with, Jesse. And Jesse worked with me the very first day that I was an addiction fellow. And he said to me, Dr. Hilmer, the definition of insanity is doing the same thing over and over and thinking you will get a different result. Sometimes attributed to Einstein. I think actually someone else said, and it wasn't Einstein, but in my mind, it's always Jesse. And this is an example of what peer support did. He challenged me, get out of your paradigm, start doing things different. Doesn't even have to be by the book, but if you do it a certain way and it doesn't work, then try it a different way the next time. And it taught me a lot. All right, final slide, and the last amazing person. You know her, I know, right? This is another amazing person I worked with at Places for People, but I also worked with when I was at SLU in a low barrier opioid clinic. This is Linda, who is a peer support specialist. She was a bulldog, man. So she would have patients, you know what I'm talking about. We would have patients together who had substance use disorders, who didn't have secure housing, and she would bring them in to see me over and over again, and then come talk to me. We got to get them into treatment, Dr. Hilmer. We can't give up on them. We got to do it. And I can think of at least 2 people who she brought back after they'd been through treatment, doing fantastic, ended up getting permanent housing, ended up working, and doing amazing. And it's because of her. So someone else actually said this to me, be someone. She was someone. So individually, if we can be relentless, we can make a difference. That's it.
Thank you. Wonderful presentation. We have time for maybe one or two questions. The audience.
Thank you, Dr. Hilmer, for this lovely talk. I always enjoy hearing you speak. When I switched to primary care about 6 months ago, I was kind of surprised at how many of my patients are using stimulants, not in necessarily an abusive way, but there's incredible use value for them. And I'm curious how you kind of approach these patients. Usually I'll go with like a harm reduction approach, but how can I get them to start thinking, oh, you know, using this, even if it's once a week, twice a week, is going to, you know, cause problems down the line?
Yeah, that's a valid question. Do you know who Carl Hart is? Dr. Carl Hart? No, he spoke at SLU. So I think that we get very puritanical in medicine when we're looking at our patients and we don't apply those rules necessarily across the board when we're thinking of other people. We don't say those things. We don't think necessarily about the harm of someone using alcohol several times a week who is our friend and our colleague. And so is methamphetamine inherently dangerous? It is, but so is tobacco and so is alcohol. I think that I lead with that first just because I think figuring out why somebody's using, what are they getting out of it? And once you've done that sort of in a way that's not judgmental, then you can ask them down the road as you build a relationship, do you want to know what I know about methamphetamine? Do you want to know what worries me about you using methamphetamine? And I think always kind of saying very matter-of-factly, this is what a use disorder is. When you're losing control, when you're having bad things related to it, are you? Sometimes it's evident that somebody is, and they'll tell you that they aren't. But most of the time, people are pretty good at saying, hey, no, I haven't lost control. And no, this is actually something that's helping me more than it's hurting me. And walking through that concept first, because then they can self-monitor and make the best decisions for them. Does that make sense what I'm saying? And then I think as you build rapport, asking permission to talk to people about the things that we know in our doctors' heads is a powerful tool. Sometimes people say, no, I really don't care what you think about methamphetamine, Dr. Hilmer. And then I'll ask again the next time I see them in 6 weeks, and they will be like, yeah, I actually trust you. And you're not somebody that's just here to, do your checklist of things. And then I'll say, I worry about your heart, I worry about, you name the other things that methamphetamine can be related to. And then you can do your harm reduction. I mean, harm reduction for people who don't have an alcohol use disorder is don't drive when you're drinking, right? I mean, these are common sense things. So does that help at all? Yeah.
Hello. My history of practice, I'm a social worker, has been with child welfare practice. It struck me when you started talking about you don't utilize the term they're clean, all that, because my history has, I've been hearing that all through the court systems. Is there any movement or any kind of education you guys are doing with the court system in regards to, because in the past it used to be any drugs, methadone clinic, that's a drug, they're not allowed to use that. What is the current practice with all that?
So we keep on talking about SLU. SLU actually has a medical legal partnership. And so my old boss, Dr. Fred Rotnick, is a leader in treatment of incarcerated people, but does a lot of work in that arena. So I'm not doing anything with this, but I know that there are people who work in this realm in addiction medicine who work with legal leaders, people who work in drug court. It's a little bit of you're navigating things there too. So not for me, but I wish I could. Yeah.
Thank you.
Thanks.
Thank you very much, Dr. Hilmer.